And with that, I am very pleased to welcome you today to today's webinar on data systems for suicides and suicide attempts. With that, I'm going to turn things over to Adam Chu.
Hi everyone, thanks for joining us again. I actually wanted to give our tech person on the line here, Dominique Liu, just a quick chance to let everyone know about a few technical details about our webinar platform, and then we'll get started right away. So take 1 second here, and Dominique, whenever you're ready, go ahead.
Hi everyone, I'm just going to review a few technical tips today. So if you have any technical problems, you can always call Adobe Connect at 800-422-3623. And during any time in the webinar, type any comments or questions into the chat box at the upper left. And if you would like to view the presentation at full screen, at the upper right, you'll see 4 directional arrows that indicate full screen. You can click that to see it full screen and click that button again to return to the regular view. I'll turn it back over to Adam.
Thanks, Dominique. So as Becca had said, we're here in the room together today to present this webinar with you today, and we also have 3 presenters for you. And without further ado, I think we have a lot to cover today, so I'll get it started. Let me change our slide here. We've got Alex Crosby from CDC. He's going to present first, followed by Ann Zenner from the state of Virginia, and then Don Bilal from Nebraska is going to close it out for us today. So I think what we'll do is, Alex, if you're ready, I'm going to move to the next slide so that you can see the start of your set, and then I'm going to turn it right over to you to kick things off for us today. The last thing I want to mention as well is in the chat pod where you've been indicating what state you're coming from, if you do have questions for the presenters throughout their presentation and throughout the entire webinar today, please feel free to type them in there, and we'll address those at the end to the appropriate presenter. So you can go ahead and chat in those questions the same way you've been doing with your states so far. Okay, so skip that one. All right, Alex, you can see the first slide of your set there, so you can take it away when you're ready. And as a reminder, you can advance your slides with the arrow at the bottom left of your screen.
All right, thank you, and good afternoon to all of you, and thank you again, and welcome to the webinar. I did want to thank the organizers, those folks at the Suicide Prevention Resource Center and Educational Development Center for the invitation to come in to talk with you and tell you a little bit about surveillance for suicide-related data and talk a little bit about some of the different aspects of this topic. Surveillance data, of course, since I work in the surveillance branch here in the Division of Violence Prevention, I have a biased interest here, but surveillance data really is critical for a lot of things that we do in public health and assessing what's going on in regards to any kind of particular health problem. It helps us in terms of defining what the issue is, determining what fits into our criteria, what doesn't, doing some of the the classic epidemiology of kind of time, place, and person. What defines what we are really looking at and what isn't, what fits and what doesn't. It also helps us to identify some points of prevention. It may help us identify what are vulnerable populations. Do we know whether it's occurring more in males versus females, young people versus older adults versus children, that kind of thing. And then also, some of the tools from public health surveillance really become very important when we're trying to evaluate some of the prevention programs that are going on. So it helps us in terms of trying to figure out whether the programs are making a difference or not. What do we know about the problem? Is it continuing as it was before? Are things getting better? Are they getting worse? What's happening in regards to the characteristics of the problem. So what I'll do is I'll try to define public health surveillance, since that's a big part of what I'll be doing. And then I'll try to give you some examples of the different data systems, what's available, and in regards to focusing on suicide-related problems. Those of you who may have heard me before or seen other things in regards to kind of what the public health approach are probably very familiar with this slide or some iteration of this particular slide. And really where I'll be talking is focusing on that upper left-hand box, assessing what the problem is. And surveillance fits into there. Surveillance is not the whole issue of assessing the problem, but is a piece of assessing what the problem is. And, as many of you know, that's kind of the who, what, when, where of any particular issue. Surveillance really does try to answer several different issues, and you may be familiar. It's the ongoing systematic collection, analysis, interpretation of health data, and it's essential for planning, implementation, evaluation of public health practice, closely integrated with timely dissemination of data to those who need to know. That's a long definition for public health surveillance. But really the shorthand of that is that it's information for action. It really is supposed to inform those who are running the programs, those who are decision makers for trying to decide what's going on and what to do about it. Move on to the next one. And why do we need injury surveillance systems? And injury surveillance is just where, at least within the Centers for Disease Control, where suicidal behavior fits, is in injury surveillance. Helps us to determine what's the problem, how big is it, who's at risk, tell us something about the precipitating events or the context or the circumstances of the events. It should be, what is often termed hypothesis generating. Surveillance oftentimes is a quick picture, a snapshot of what's going on, but it may lead us to asking more questions that give us more detail. But surveillance can give us some parameters, some general overview about what's going on, and how do we design the research to find out how to prevent the problem and test it in a community. Surveillance can oftentimes give us the direction to go. It may tell us, whether males are dying more of suicide than females attempting more than males, and can give us some parameters for getting started with what's the issue, but then can spur us on to asking more detailed questions. And then also it can assess the result of programs, as I mentioned, how we're going to evaluate what's going on. Changes in deaths, in injuries, impairments, disabilities, lost work days, loss of ability to perform daily activities or behaviors. This slide is just depicting kind of the pyramid of the scope or the burden of suicidal behavior, and applies to across a number of different health topics. But if you look at the top of the pyramid, deaths really represent just a small portion of all of the injuries, all of the fatalities that are associated with suicide and suicidal behavior. It's an important piece, but it's just one part of it. Hospitalizations generally are much a bigger number, and then you can look at emergency department visits, and then when we've asked on surveys about, maybe in the past 12 months or in a lifetime, have you ever attempted suicide, engaged in suicidal behavior? That's oftentimes a much bigger number. And in some surveys in which they've asked people about whether you told anyone about this suicidal behavior, sometimes that's an even bigger number in terms of the unreported events. This is just an example of data from one particular year, national data in the United States, looks at the burden among those 10 to 24 years of age for self-directed violence. So some of it is not all suicidal, but definitely the deaths represent suicide. And this is from 2010. You can see up at the top of the pyramid about 5,000, a little less than 5,000 deaths, and a rate of about 7.6 per 100,000. Hospitalizations much bigger, over 35,000, so almost 8 times more hospitalizations for fairly serious suicidal behavior than there were deaths. And then you can look down at emergency department visits, over 174,000 emergency department visits for that self-directed violence. And you can kind of see the magnitude going from a little bit over 4,800, 35,000, almost 36,000 to 174,000. So the magnitude increases as you look from fatalities to non-fatal behavior. Let me give you some examples now of some of the different data systems and information that's available regarding suicidal behavior, and I'll start off with the deaths. Of course, many of you may be familiar that death certificates in your state can give you information. You can look at the national numbers to maybe give some background, to give maybe a reference point. So national data is available also at the state and also at the county level. So oftentimes you can get to much more detailed and more specific information looking at death certificates. Another example is the National Violent Death Reporting System, which currently operates in 18 states. I'll talk about that in a little bit more detail in just a minute. Another system that CDC operates is called the School-Associated Violent Death Study, in which we've been looking at school-associated violent deaths, primarily homicides and suicides, since about 1991. That's just available on a national level, but gives some ideas about homicides and suicides that occur on school property, at a school-sponsored event, or are associated with someone traveling to or from school. So that gives you some idea about some of those things that are going on. I'll talk a little bit more in detail about the National Violent Death Reporting System. Its mission is to collect high-quality, detailed, timely information on all violent deaths in the United States. It has three primary sources, even though there's four listed here. It looks at death certificates, coroner and medical examiner records, and police records, law enforcement records, really. And in many states, also includes that crime lab data or toxicology information. I'll put in a plug here right now because there was just a funding opportunity announcement released for the Violent Death Reporting System, and it's actually expanding from those 18 states to approximately 28 to 30 states. So there may be some opportunity for those of you that are in states that don't have the Violent Death Reporting System, that there may be some folks within the health department, because that's usually who is the awardee within the state, to working with them, regarding some of the data that they may be collecting. What the Violent Death Reporting System does, it tries to integrate data from these diverse sources to give a more complete picture about what's going on in regards to suicides, and tends to report faster than vital statistics. The system includes suicides, includes terrorism, homicides, also includes terrorism, events of undetermined intent, unintentional firearm injury deaths, and then legal intervention deaths. And as I mentioned, the plans to expand from 18 to about 28 states in 2014. These are the states that currently are funded as part of NVDRS, and you can see that there are states are represented from the East Coast all the way to the West Coast, some in the South, some in the North. So quite a diversity of different states that are involved. The process has been a competitive process, and so there's no real regional representation here, but have been the states that have been able to put together the best applications and carry out the mission of the Violent Death Reporting System the best way. Part of what this does is within the Violent Death Reporting System, there are different modules that cover the different forms of death. So homicides, there's a module there that asks some specific questions about the circumstances of the homicide death. Same kind of thing with suicides, in which it asks questions that might get at some of the issues regarding, was there a relationship problem? Was there some sort of crisis within the past 2 weeks? Had there been a financial problem for the decedent? Do we know about some of their medical or psychiatric history? Do we know about whether they were under treatment? So some of those questions that might be very important for those doing prevention activities to understand some of the context, the precipitating factors, the circumstances that were associated with the suicide death. Now move on to non-fatal injuries, some of the official records in regards to that. One example is the National Electronic Injury Surveillance System. That's really a sample of hospital emergency department visits. I'll talk about that in a little bit more detail. It is only available at the national level, but again, may give some examples of kind of some background or a reference point for what's going on in that regard. There are other kinds of hospital records for which you may be able to get access to and locally, and that's in terms of emergency department. Sometimes, if there might be a trauma center in your area that specifically might see some of the, especially the more serious cases of suicide attempts, you may be able to get information from them. And then lastly on this one, hospitalizations. Oftentimes state hospital associations will have the kind of information that that has external cause codes. That tells you whether something like a gunshot wound was an assault related, or was it suicide related, or was it an unintentional injury. But oftentimes with hospitalization, state hospital associations may have that kind of information. The next one is talking a little bit more about the National Electronic Injury Surveillance System. It's actually operated by the Consumer Product Safety Commission. CDC developed a collaboration with them in which we expanded that system while it was an emergency department system that just collected information about consumer products to expand it to cover all forms of injury. So the system that we help operate is called the NICE AIP, so that's All Injury Program. Collects data on all types of external causes of injuries and poisonings treated in U.S. hospital emergency departments. What it does is to get a sample of hospital emergency departments across the country based on some of the different strata, the strata being the size of the emergency department in terms of how many patients they see. So they've got from small to medium to large to very large emergency departments in terms of the number of visits they get, and also includes children's hospitals in there also. This is how the case definition is used in the NICE system, which is a self-harm definition: injury and poisonings resulting from deliberate violent act inflicted on oneself with the intent to take one's own life. We've looked at the system also to try to distinguish how many self-harm injuries are there from specifically suicide-related, and have developed an algorithm for looking at that, and have been able to go back and look at the data to try to define the difference between some of those. These are some of the different data elements that are collected there: demographic, disposition, intent, principal diagnosis, and some of those kind of information. Here's one place that you can get access to some of the mortality data, vital statistics data, NVDRS data, as well as the NICE information on our Whiskers website, WISQARS, and if you go and look at it, that's a cougar. So I used to always say that was a cat. It's really a cougar, and he will actually wink his eye and twitch his whiskers at you, just in case you need some entertainment. I know a lot of you might go to those kitten websites, so this one is a big cat. You can take a look at that too. Let's see. The next one has to do with some of the survey-related information that's available. We've got the Youth Risk Behavior Surveillance System, and many of you are probably familiar with that. You may have used that as part of your Garrett Lee Smith activities. It looks at high school students, has 4 specific items on suicidal thoughts and behavior, collects data that's nationally representative from 43 states, and then also from 21 large urban school districts. And then there's also the National Survey on Drug Use and Health. That collects information on adults 18 and above, has 6 items on suicidal thoughts and behavior. Of those 6 items, 4 of them are identical to the questions that are asked on the Youth Risk Behavior Surveillance System. So especially those of you that might be doing programs or focusing programs on that 18 to 24 age group, the National Survey on Drug Use and Health may be useful for that. It is collected at the national level, all 50 states and DC, and 33 large metropolitan areas. The Youth Risk Behavior Survey is a system that collects data on a variety of health problems, which may allow you to do some association between things like binge drinking or assault-related violence or sexual assaults or dating violence, and how that connects up with those that mention suicidal behaviors. Collected every other year. The suicide thoughts and behavior questions are asked over the past 12 months. These are some of the considerations for the data that we're doing, and I'm going to wrap this up, is diverse data sources are usually important and helpful in regards to collecting information from various sources, because they oftentimes will complement each other. Helps you get information about the circumstances. Some of the sources that I didn't mention is that there may be a possibility of looking at EMS data in your local region, and linking data between systems may also be helpful. And then access and dissemination. How timely is the information? Is it something that maybe you can get daily, weekly, quarterly, or something that may only come out once a year? And then what are some of the reporting requirements? In conclusion, assessment is a foundation for public health. It is critical for us to kind of get surveillance information that gives us some characteristics about the problem. Existing systems for assessing self-directed violence are useful, but they do have limitations. None of them are perfect, but oftentimes they will give us a quick overview of what's going on. And then the need exists to improve these systems and expand them regarding self-directed violence, looking across some of the different things, the gaps that we have in the mortality and in the morbidity area. So thank you very much, and I know we're going to take some questions, I think, at the end.
That's right, Alex. This is Adam again. Thanks very much. Alex is right. We'll be taking questions at the end if you have any that come up throughout the rest of the presentation. So, Alex, thank you very much for your presentation, and hopefully we'll hear from you towards the end again with some questions. I'd like to introduce our next speaker for today. We're going to hear from Ann Zenner from the Virginia Department of Health, and let's move ahead there to Ann's slides. Thanks very much. Ann, if you are ready, I think we're ready for you. So go ahead.
Okay, great. Hi, I want to first thank Adam and Becca and the FPRC for inviting me to participate. I'm happy to have the opportunity to talk with you today. Today I'm going to present some information about how Virginia tracks non-fatal self-harm incidents among Virginia youth. And if you kind of think of that pyramid that Alex presented, we're, beyond that kind of chunk of deaths at the top, we're a little bit further down in that pyramid, able to present some hospitalization information. So if you kind of keep the pyramid in mind, it might kind of help you understand the universe of what we're talking about as far as suicidal or self-harm events. So as an overview, first I'm going to talk about Virginia's data sources, and I'm going to discuss a little bit about obtaining and maintaining access. I'm also going to talk a little bit about management and analysis resources that are necessary to make use of these sources. And I'm going to talk briefly about the limitations of these data sources, because there are a few, as is almost always the case with your epidemiologic data. And then I'm going to sum it up at the end. So there are two main data sources for self-harm kind of attempt data, or getting at that data beyond just deaths here in Virginia. The first of those is our hospital discharge system. And the second is our syndromic surveillance data system that's also called Essence. Most state health departments have access to resources of this type somewhere internally. Essence is what we would refer to as a syndromic surveillance system. So what that means is a system of aggregating chief complaint and other data to characterize a health risk. It's typically used to track outbreaks of infectious disease like influenza or salmonella, or bioterrorism events, but these systems, and there are several of them, have a wide variety of other applications. There are a couple other platforms besides Essence. There's one called Biosense, and there's another called EARS. So there are multiple packages that are available for this sort of thing. And our use of Essence is really a repurposing of a data system that's already in effect and being used to track other health outcomes. Essence is very different from the discharge data, and I'm going to talk a little bit about how that is in a few minutes. So our hospital discharge data includes cases from all non-federal acute care hospital discharges occurring in Virginia. So in Virginia, an entity called Virginia Hospital Information collects discharge data from all non-federal acute care hospitals. That means that it excludes things like VA facilities and hospitals that don't provide acute inpatient care. That data set includes information such as diagnosis codes, E-codes or cause codes, which are codes that specify the intent and the mechanism of an injury and would be important for suicide data, as well as things like total hospital charges, payer source, and state residency information. When I analyze this data, I can determine if the case has survived to discharge, which may or may not be an outcome I'm interested in as well. Typically, I refer to a set of national standards that are published by the Injury Surveillance Work Group to give me direction in how hospitalization data should be analyzed for injury and violence surveillance. And I wanted to say at this point that all of these comments about the inpatient discharge data would also probably apply to emergency department discharge data. In Virginia, we don't have access to that data source yet, so I can't really speak to it. But some state health departments do, and that data would presumably be set up in a similar way to the inpatient data. This is just an example of what, of kind of an output from an analysis of our hospital discharge data. And this is all ages that I had age adjusted. So this isn't just restricted to youth, but these are rates between 2003 and 2012. As you can see, females have higher rates than males, and that's pretty typical in the hospitalization self-harm data. When you think about the different types of means that men and women typically choose for self-harm injuries and how likely those are to be more lethal or to cause death before someone could get to the inpatient status. And then I'm going to talk about Essence a little bit. So Essence is a data product developed for syndromic surveillance uses by Johns Hopkins University. So when I say syndromic, what I mean by that is a system for collecting and aggregating chief complaints data, or it's not a traditional surveillance system in that you would have active cases being reported to the health department. By chief complaint, what I mean is the chief complaint that's actually written in the patient's record. So it might say something like patient seen here for suicidal ideation, and that would be written all out in a text field. And Essence allows you to kind of search that text field and pull out the information about suicidal ideation or a suicidal attempt. In Virginia, 120 facilities currently report data through Essence, including 13 freestanding emergency departments, 69 hospital EDs, and 38 urgent care centers. There's not complete coverage in Virginia, but it's still helpful for surveillance in kind of getting us further down that pyramid toward, kind of a larger number of those cases that you don't know about just through death data. New facilities are coming online each year here in Virginia, so that sample is growing over time. Data analysis for this data is more complicated and requires more refinement over time. If you're searching text field data, you're looking for specific terms, and you have to account for things like misspellings and abbreviations that clinicians might use. So it's not the same as analyzing, say, a hospital discharge data set. This is an example of some data I pulled out of Essence last week for this presentation. This is, again, all ages, and that's for 2013. That's the total count of the number of cases that met the terms of the suicide query for each of the months in 2013. And as you can see, that activity is fairly stable over time. So, and then a few words about data access. Our hospital, it's fairly common for a health department to have access to inpatient discharge data in some form. Our data set was developed in the 1990s, and it was mandated by state law. The entity Virginia Hospital Information, or VHI, was named as the entity to collect the data, and the Virginia Department of Health was named as the receiving agency. So we received that data as kind of a pass-through from VHI at no cost, so and to be used for public health purposes. I know that it is the case that individuals can go to VHI separately and request data, but I think there's typically a fee for that. So we use the data regularly to track injuries and violence, and other programs use it for things like chronic disease. My particular office with NVDH has had access since 2005. I think previously this data had been kind of warehoused in a different organization, in a different unit within the Virginia Department of Health, and so we didn't always have direct access. But the ways we've chosen to use the data have grown in complexity over the years as we've gotten more experience. The data itself are managed by another office at VDH, the Office of Information Management. That's a pretty considerably large data set. You're talking about more than 800,000 discharges a year. So if you're talking about 10 or 15 years worth of data, that's quite a big data set and requires some special skill. So our Office of Information Management folks kind of handle the management of that themselves. State access, as I said, to hospital discharge is typically through some sort of hospital association. There are data use requirements that govern our access. There are restrictions on how the data may be used and what we can report, because this is data about, in a lot of cases, about living people. So I have a username and a password to access our data through a secure server, which adds another layer of security. And I can't see personal identifiers in my version of the data set. Those don't get reported to VDH. State injury programs commonly have some form of access, so you should check with them. We have policies, for example, also about reporting small numbers and small geographic areas to protect confidentiality. And there are a few tricks to managing large data sets that I'm going to talk about on another slide. But it's handy to keep in mind that there do need to be some policies for reporting small numbers and rates. Access to Essence is typically restricted and requires a secure login. It's restricted by job function and by geographic area. So our district EPIs out in the health districts here in Virginia do have access to Essence, but I know, for example, that they can only see the data that's related to their health district. So depending on what kind of user you are within the system or within a similar system, you may or may not have access to the full state level. If you want access to some form of syndromic surveillance data on Selfharm, you would probably have to work with the work unit that manages your data system to design a query and then have them give you some form of regular report on the output. In Virginia, our system is managed by the Division of Surveillance and Investigation, which is the office that handles disease outbreaks. So we've had to work with them to kind of get up to speed and get access. You may have to request data from a similar work unit and have them help you design a query. I'm going to talk a little bit about management and analysis resources. There are a few resource implications for working with both of these types of data. First, there are management issues that are specific to large data sets. For example, sometimes the systems for storing that sort of data are different and more complex because of the size of the data set. I know that's the case with ours. And working with larger data sets is also a particular skill set and it requires more experience with data cleaning, data manipulation of large data, and data standardization. Someone would also need training and experience with statistical software packages like SAS or Stata and facility with coding and statistics. Staff need to have some experience working with injury data, specifically with ICD-9 coded data. That's ICD-9-CM is the coding standard used for morbidity data. And all of your hospital and ED discharge diagnoses are going to be coded in ICD-9-CM. So someone who's expected to work with this system on a regular basis does need to have some familiar with ICD-9-CM. You also need to be familiar with the national standards for reporting injury data from ICD-9-CM coded data sets. There's a reference at the end. The Injury Surveillance Workgroup publication serves as a guideline for that. And for Essence, you're going to need familiarity working with chief complaint data. For example, the use of clinical abbreviations, nursing and medical terms for chief complaints, and running queries on text strings. So this data all comes out, kind of parsed out in a sentence, and you have to use code that actually pulls out, you have to use the query system to actually pull out individual words that make your search terms. You'd also need some experience working with a query system. So Whiskers is an example of a query system. Essence is a little bit more complicated, but it basically operates like a query system on the front end. There are some limitations to these data sources. So for hospital discharge data, your self-harm hospitalizations are going to be not representative of all self-harm injuries. What I mean when I say that is that, for example, in Virginia, about 90% of the hospitalizations that occur due to self-harm injuries are actually due to poisoning. So that's not indicative of all of the self-harm injuries in Virginia. But if you consider that there are differences in the types and the severity of the injuries caused by different self-harm means, that actually makes a little bit more sense. So there's some means, such as firearms, that are going to be a little bit more immediately lethal, and those patients would not survive to actually admission. And then there are going to be some injuries that can be treated in the emergency department and never need a full inpatient stay. So that hospitalization data is not going to include those cases where someone either died at the scene or died in the emergency department, or whether they were treated in the emergency department and then released. So it's not fully representative of all of it. For discharge data, there's also a reporting delay of about a year. We currently have the first half of 2013 in our data set, and we're waiting for a second half. For Essence, kind of the main limitation is that you have incomplete coverage of facilities. Not all the EDs and urgent care centers currently report. So it's helpful for giving kind of an indication of what things look like, but it's not a complete population number. Also, you have to remember you're analyzing text field data. It takes some trial and error to structure your query to catch cases. And Essence is also missing some types of data common to discharge data sets. There aren't very many diagnosis codes, for example, get used infrequently. E-codes may or may not be used. And there are some limits on demographic data and no information about, say, hospital charges or maybe the payer source as well. So to sum up Virginia's approach, we've been very successful at leveraging existing data systems that were already in place. Both Essence and the hospital discharge data were already available to the health department and have kind of been repurposed for injury uses over time. We also rely on data management protocols that are already in place and kind of develop those as needed. So there's some guidelines that we kind of keep in the back of our heads. And those kind of develop over time. You will periodically, I periodically find that there are issues with our discharge data set that you kind of have to go back to the data set and resolve. And that does typically happen over time. When new systems come online, EPI staff need to take time to become familiar with working on them as well. So you kind of have to develop a new skill base as you get access to these new systems. Essence is a very new system for me to have access to. So I'm still kind of working out how it will be useful for us. And then it requires collaboration with program staff, EPI staff, data management staff to effectively maximize the use of the data. So I talk all the time with our Office of Information Management staff and with our Division of Surveillance and Investigation folks regarding Essence to kind of make sure I'm doing the right thing, to make sure that the data set is doing what it should be doing, and to make sure I'm interpreting things the correct way. This is the reference on from the Injury Surveillance Work Group. Consensus recommendations for using hospital discharge data for injury surveillance. Even if you're program staff and you don't actually run data yourself, you should be familiar with the methodology it discusses. It's important to know how the numbers an epidemiologist gives you are calculated. It serves as kind of a national standard for discharge data analysis and for injury and violence. And it ensures that data are consistent across areas and programs. It was published in 2003. To serve as a consensus standard for injury surveillance, and it's used widely to promote uniformity in reporting between areas and programs. The state and territorial injury prevention directors, STIPTA, that it references there on the screen, is actually now called Safe States. So this document is available on the Safe States website, and with that, I'm going to turn it back over.
Great, thank you, Ann. That was really interesting and informative. Before I introduce our last speaker, I'd just like to remind you to put any questions that you may have into the chat pod on the left-hand side of your screen. I'd also like to call your attention to the resources directly below that pod. You can click on a resource and browse to it. It includes a training from the Suicide Prevention Resource Center on locating and understanding data. So that could be very helpful as you move forward. With that, I'd like to turn things over to our last presenter, last but not least, Don Spielaw. Don is the Dean of Doan Masters in Counseling Program in Lincoln, Nebraska, and he's been the co-chair of the Nebraska Suicide Prevention Coalition for over 10 years. Take it away, Don.
Hey, thank you very much. I appreciate the opportunity to speak on this particular topic. As you can tell, this is a model that we use in Nebraska that allows us to collect information specifically relating to the deaths of children and adolescents to suicide. So I'll be speaking to that element specifically rather than speaking in relationship to adult suicides. I'm a member of the Child Death Review Subcommittee, which allows us to take a hard look at the issues that confront Nebraska's youth as many have died by suicide. The fact is, our suicide rate for young people in Nebraska from ages 10 to 24 unfortunately exceeds the national rate and is considered to be the second leading cause of death for Nebraskans in the age group of 15 to 19. Having said that, I've established, I think, the importance of collecting data and then being able to interpret what the data might mean in terms of implications for program and prevention. So as we move through these slides, feel free to make some notes and ask questions that we can all respond to as a panel. As you can see, this particular slide indicates that the Nebraska Child Death Review Team was established several years ago, and it had the undertaking of completing a review of existing records so that we can, as a team, provide recommendations to the governor, the legislature, and other policymakers in terms of what may be creating an environment where children and adolescents die by suicide. So we look at the actual number, and we look at the causes of children's deaths, and we attempt to then try to use the members of a child death review team to evaluate possible scenarios and situations that have contributed to the death of a child or an adolescent by suicide. In other words, we're looking at the end of the consideration, what could have been a reasonable intervention that might have prevented a death by suicide of a child or adolescent. So as you can see, this particular purpose of this group of individuals has a great amount of meaning and possible impact. But how do we go about doing that and collecting that information? Well, we use the opportunity to collect information from a variety of sources and causes. To some extent, in Nebraska, compared to other states, we have a bit of a challenge in that we do not have a statewide coroner system, which then makes it somewhat difficult to acquire systematic information regarding the deaths of our children and adolescents. So as a result, we are attempting to continue to find different arbitrary pieces of information that will help us get a sense of what that child or adolescent may have been experiencing at that moment that led to the death of the child or adolescent. Some of the data sources that we do use will include certainly vital record sections of where we secure death certificates. We also utilize the electronic databases that are available to us as well, which is most states have that opportunity. But as we look at the data sources, you'll see where we start looking beyond just the numbers, but we look at personalized sources of information within the communities where these young people have raised. For example, the county attorneys. County attorneys have access to a variety of information that could be very useful in understanding the possible influences that might have impacted a child or adolescent. We also attempt to secure information from a variety of private providers within that particular area as well. Newspaper reports. We search for newspaper reports that can give us some sort of, again, clue in terms of the possible influences and factors that might have been involved. We also are able to secure information from public school settings and private school settings as well, oftentimes where these administration individuals are willing to provide responses to queries where we ask for more information relating to that particular individual's behavior. As we go through the cases in terms of evaluating the processes that may have impacted these individuals, we have our reviewers and our team will then take a very close look at this data because we're attempting to identify whether or not perhaps the death may have been preventable. And we have guidelines that establish definitions of how a suicide death could have been considered preventable. For example, we look at the idea that if an individual or community could have reasonably done something that could have changed the circumstances that led to the death of a young person, then we would consider that to be preventable. We utilize a categorical process as a team to evaluate whether or not the situation could have been preventable. We utilize these categories: strongly disagreed, somewhat disagreed, or neutral or undecided, somewhat agreed, or strongly agreed that the death may have been preventable. When we look at neutral or undecided category, oftentimes we look at this category as a result of simply not having enough data or enough information that one can lead the reviewer to some sort of conclusion as to whether or not that death could have been preventable. By using this type of process, we've been able to, as a child death review team, being able to move to a process where we can classify with some degree of confidence that perhaps the death may have been preventable or not preventable. As we all know, that when we start looking at the specific cases that do confront teams such as the child death review team, oftentimes the information may not be complete or may be inaccurate. So there is certainly a risk that misclassification can occur. But in order to reduce that possibility, team members do look very carefully at all the data to try to come to some reasonable conclusion. We need to point out that as a part of this child death review process that it's certainly not a substitute for action that can be taken by families and communities on any particular level, but it's a process of reviewing and providing some sort of methodology of collecting a sense in terms of what communities could do in terms of responding collectively to these issues. We now have a number of examples of issues and our child death review team recommendations that do address pretty squarely some of the issues that the child death review team identified, and some recommendations that have been provided to the governor and to the people of Nebraska. As you can see on this particular slide, one issue that was identified was some providers who engage with troubled youth may be unaware of the range of factors and circumstances associated with suicide. At the same time, many high-risk youth are not receiving adequate and ongoing assessments from mental health specialists. This specific issue was developed as a result of reviewing numerous case files that indicated that there was a linkage among a number of youth who could perhaps be defined according to this particular issue. As a result, then, recommendations were developed that were specific in nature. For example, the Nebraska Departments of Education, Health, and Human Services should partner to locate and train suicide prevention specialists in schools and educational service units. The specific suicide prevention specialist that is addressed in this particular recommendation is in connection with the American Association of Suicidology suicide prevention specialists, where individuals across the country in various school districts could receive training in how to promote suicide prevention within that local school district, and hopefully therefore raise awareness. That was an example of a process that the child death review team had a degree of confidence that would make an impact. Other examples that have come about, as you can see, are relating to the concerns that the child death review team had regarding the possibility of mood stabilizing medications perhaps being not closely monitored in an efficient manner. As a result, that recommendation has been offered. On this slide also is suicide risk assessments, either formal or informal, that are recommended by the child death review team. Schools, mental health and chemical dependency providers, law enforcement, pediatricians, as well as ongoing awareness that inquiries about teens' postings on social networks regarding suicide ideation need to be identified by these groups of individuals as well as parents in general. So these particular recommendations, as you can see, certainly move from looking at the collection of data and the sources of the data into moving to, as what Alex mentioned earlier, about information for action, which is what the ultimate goal of collecting data is about, is moving forward with an impact. Another issue that we had noticed through a review of the material was that a number of Nebraska youth had apparently access to firearms. Our recommendation was simple and straightforward, that when the youth are identified as being at risk, that simple precautionary steps should be made to manage access to the ammunition and weapons in that family unit. The next unit, as we kind of move towards the slide, as we move towards the conclusion, is, I think, a particular identification of an issue that certainly has caught the child death review team's attention. That 25% of the youth who had prior involvement with agencies would indicate that we should be encouraging this agency to include assessments of suicide history and risk with young people, to establish a safety net, if you will. Other recommendations have been included in terms of looking at the data was training for those who have direct contact with youth, where, for example, the HHS Child Protective Services staff and contractors should be able to assess a youth's level of depression and suicide ideation as they move through the system. So as you can see, as we move forward to the end of my particular part of the presentation, Nebraska is utilizing a variety of different sources of information to collect data that can be interpreted and be shared with policymakers on all levels, whether it be on the state level or the local level or within the other interventions that different groups may have for children and youth of Nebraska in an effort to promote suicide prevention through awareness and utilizing evidence to promote these activities. So with Adam, I can turn that over to you. I've covered the information that I've been able to address.
Don, that's great. Thanks very much for turning it back over, and thank you very much for your presentation. So as you can see by the slide on the screen, we've moved on to a question and answer period. We did have a few come in the chat box, so we're going to address those. And if you have any follow-up questions that come along, please do type them in. I know I have a few questions of my own as well. So why don't we start off with the question that came in from Richard McKeon. It's directed towards Ann. It reads, can you give an example of how you've used the Essence system to plan suicide prevention activities or priorities? Ann, you want to go ahead? And I believe Alex has a follow-up to that as well. So Ann, why don't you take a crack at that one first?
Sure. Yeah, so thank you for the question. I think because Essence is not, we don't have complete statewide coverage of Essence, I think really right now what I would use Essence for is to give me kind of a first indication of where there might be more of a problem. So, you know, of course you do have your hospital discharge data as well, but there is some geographic information in Essence, so I can look at these cases by actually down at the hospital level, or at the ED or urgent care center level, so I can actually see kind of where these cases are coming from. And I think a potential data use of Essence would be to look and see where your burden is. This is data that I can't see in the hospital discharge data. It's strictly emergency department and urgent care center. So I think it gives me a response to, it gives me kind of a deeper look at some of the data that I get in the discharge data. And I can see where that might be helpful for kind of targeting interventions. Say, if you wanted to work in a particular community where you knew there was a pre-existing problem, Essence might be a good way to see where your burden was. Is that helpful?
Thanks, Dan. I think
And this-
that one covered, yeah, go ahead. I was going to say, I think that covered that one. And Alex, I know you wanted to add on, so please go ahead.
Yeah, this just to address that also. We at CDC had looked at the BioSense system, which similar to what Ann mentioned, that Essence system is a syndromic surveillance system. We had done some initial work, as Ann mentioned. You had to take a look at some of the chief complaints, make sure you were correcting for spelling, be able to kind of write a query system, something that would go in and look for certain terms within the information. One of the things that we saw, now we haven't been able to actually utilize it for a prevention program, but one of the benefits that we saw was that with the syndromic system, it was a real-time system. So in essence, you could get information from that system within a few days, if not the same day, or within a week of what was going on in terms of emergency departments. So one of the things we were starting to look at was, you could look at some seasonal variations. Is something going on around the country, or in the areas that are that collect data about changes in regards to those coming to emergency departments for, in some cases, we look at suicidal thoughts as well as suicide attempts. So not only kind of the timeliness of the system, but then also looking to see how it might correlate with some of the other things that might be going on, whether that's regionally or nationally. As many of you might be aware, as we were going through some of the economic downturn, there were a lot of questions about how that might have influenced suicidal behavior. And definitely as we started to look at it, you could definitely see some changes, primarily with ideation, but we could start to see some things that were going on in regards to ideation at the level in which the data was collected, along with what was happening with the economic issues going on in the United States. So definitely kind of the timeliness issue and being able to look at some of the information in connection with other kind of local or climate or environmental kind of things that may be going on.
Great, thanks very much, Alex. And I wanted to, before we go to the next question that is also for Ann, just address Debbie's question in the chat box there about access to the slides. We will be posting these on the SRC website. All the slides may not go up at the same time for various clearance reasons and such, but they will be there, and this webinar will be archived as well there when the presentation is done. So we'll send out a follow-up email about that so that you know when you can access those. So why don't I jump to the question that came from Brandy. She asked, I'm assuming that hospital discharge data includes psychiatric hospital data. And Ann, I believe that was for you, so I'll let you take that one on.
Hi, yeah, thank you. So actually, it's kind of to the extent that hospitals would be classified as acute care facilities, they would be included. Say, for example, there are psychiatric wards located in acute care hospitals, so presumably you would be getting that information. But it's my understanding that if they are not acute care hospitals, which a lot of psychiatric facilities, I'm not sure that they are, then they wouldn't be included. So that's the main kind of takeaway, is that these are acute care hospitals only, at least in my data set. That may not be true in all states. So I don't know. I'm not sure. To the extent that they were classified as acute care, they would be included, and to the extent that they're not, they'd be excluded.
Okay, Ann, thanks very much. Well, I had a question for you, Don, actually. You had mentioned that as a part of the team, you in the past or have and currently can submit queries to schools for information. And I'm wondering if you could give us a little more detail about what that looks like and what kind of relationships that requires. I know sometimes in the work the schools can be a little apprehensive to share that kind of information. So I'm curious as to what that process looks like and what the relationship building process was as well in order to have that kind of access to the information. So Don, go ahead if you can.
Yeah, yes, Adam, thank you. Certainly it's a school-by-school situation, but some of us on the team have relationships with some of the different administrators, such as the counselors or the school principals in a particular district, and they're willing to share in a very confidential manner, if you will, some information that could be useful to be integrated in our understanding of the situation. So I think having a relationship with small school districts in particular across the state allows us to get another sense of what may have transpired. We also are able to, I think, communicate with county attorneys and law enforcement on the same level. And not only are we able to read the reports that are filed, but we're also able to contact some of these individuals personally and ask for more information that may have not have been provided within a particular report. So it gives a qualitative sense to understanding the situation, Adam. And I think, again, one has to be respectful of confidentiality and so forth, and the sensitivity that goes with the family's perceptions of the experiences that they've had. But we are able to be able to move ahead, again, from moving from just looking at a number to getting a sense of who a child or adolescent actually was.
Thanks very much, Don.
Yes.
I had another question, actually, for, this one's actually for Ann. And you mentioned that you're in communication fairly regularly with the Information Management Office, some of the more complex data that comes back. So when it does come to you, I'm not sure exactly what condition it's in. I think you mentioned there's some cleaning and reorganization that they do. What does the rest of the process look like for you to produce something, like the figure that you included in your slides or other information that you would share with stakeholders?
Yeah, the information management folks strictly kind of manage the data in data sets. So they do a little bit of analysis work, but I don't typically ask them to do that because that's a skill that I have. So on my end, I have to go into a program such as SAS or Stata and actually give it a command to kind of read data from a secure server and then pull that data down and actually run SAS code to actually generate counts or rates or whatever I'm interested in. And then usually I'll, to make the nice looking graphs, I'll export it into Excel, and because Excel makes nicer graphs than SAS does. So that's typically the process. It does require coding skill because, information management folks typically, they manage the tables that the data is in, but they don't do the analysis on our end. So all the analysis work is what I have to do.
Okay, great. Well, I don't currently see any more questions or anyone typing in the discussion chat pod over to the left. So what I'm going to do is I'm going to turn it over to Becca. And thanks for those of you that asked questions, and thanks to our presenters again for answering them. Becca, you can go ahead.
Great. Thank you, Adam. Again, I'd like to thank all three of our presenters today. I think you provided a wide array of information and strategies for collecting data on suicide and suicide attempts and ideation in a variety of settings. So thank you for that. I'd like to remind you that we do have this resource link pod, which is underneath the chat box. That very first link, if you click on it and then hit the Browse To button in the bottom of that pod, it will take you to a training which SPRC provides for free online about how to collect and understand data in your state. So that could be very helpful for those of you who are still trying to wrap your head around all of the options that are available. There are other resources available on that list as well, so be sure to check those out. In the coming days, you'll receive an evaluation over your email. We'd really appreciate your feedback on today's webinar. It helps us make sure that we're meeting your needs and doing the best job we can. So be sure to reply to that email once you get it. And with that, I think we're ready to wrap up. We're wrapping up a few minutes early today. I hope you take the time to enjoy your weather wherever you are, or take a coffee break, do something for you. And with that, thank you very much. Take care.